Welcome to Insight Ophthalmology. This is Dr. Amrit, welcoming you to another advanced lecture. Today we are studying how to evaluate a case of anisocoria. So, what is anisocoria? Anisocoria basically means when there is unequal pupil size. So, as can be seen in this picture, the right eye has a bigger pupil and the left eye has a smaller pupil. So, whenever there is unequal sizes of the pupil, it is referred to as the anisocoria. Now, this condition can be physiological as well as pathological. So, what is meant by this physiological anisocoria? The physiological anisocoria is a term. It is referred to anisocoria when the difference in size of the pupil is about 1 mm or less. That means if one pupil is about 3 mm and the other pupil is about 2 mm or vice versa, the difference between them is about 1 mm, right? So any difference which is greater than 1 mm will fall into the category of pathological anisocoria, and you need to evaluate those cases. So that's the first criteria of physiological anisocoria. Second thing is the pupil size disparity or difference will be same in light as well as in the dark condition. So this is what I will tell you as we go on along the lecture. So what happens in anisocoria is that we try to examine the patient both in a light environment, both in the presence of light and also in a dark environment, in order to differentiate which pupil is abnormal. Now, in physiological anisocoria, because both the pupils are actually normal and there is just a physiological difference in the size of pupil, these two pupil will, the difference between them will remain same in light and also in the dark environment. And moreover, the two pupils will react normally to light. Okay, so these are the three criteria to call an anisocoria as physiological. Now, what if the anisocoria is not physiological but a pathological anisocoria? Then, how do you go about evaluating such a case? So, first of all, the history is very important. So, you ask the patient, when was the anisocoria first noted? Was it present right since birth, where you might be dealing with a congenital condition like congenital Horner syndrome? Or was it associated with any symptoms or signs? Like sometimes the patient will have drooping of the eyelid or restriction of the movements along with anisocoria, in which it might be a third nerve palsy where we know we get a dilated pupil. Or sometimes the patient will have redness of the eyes along with a small pupil that can happen in uveitis or iritis. Now, was there any ocular trauma? We know that trauma can also cause damage to the pupillary sphincter, and such as traumatic pupillary sphincter will not constrict in response to light, right? So, such a pupil can also present as anisocoria. So, history of ocular trauma is also very, very important. Then you ask about any usage of eye drops or ointments. Again, a very important point because sometimes the patient might have used certain cholinergic agents or anticholinergic or sympathetic agents, which will lead to the constriction or dilatation of the pupil, respectively. Then, of course, you ask for any symptoms of syphilis or any history of syphilis because that can also lead to certain pupillary conditions like the Argyll Robertson pupil. Then sometimes you also ask for the old photographs so as to compare whether anisocoria was present previously or at what age it appeared in the patient's life. After taking a detailed history, the next thing is the ocular examination of anisocoria. So, the first thing that we do when we encounter an anisocoria, that is unequal sizes of the pupil, is we are going to compare the pupil size by taking the patient in light and dark environment. So first you compare the pupil sizes in light and then you compare it in the dark to see if the difference is, if there is any change in that difference of the pupil sizes in light and in dark. And the significance of this test is what I'm going to tell you as we go on. Then you also test the pupillary reactions for the light and also for the near reflex. Now, this is very important because in certain specific conditions, we get what is called as the light near dissociation. So, what happens in light near dissociation is that the patient will have a preserved pupillary light responses to the near reflex. However, the light reflex will be absent. That means the pupil will not constrict in response to a torch light. So such condition is called light near dissociation. So you have to test a patient of anisocoria for the pupillary reaction to both light as well as near. Then you evaluate for the presence of relative afferent pupillary defect. Now, anisocoria most of the time is an efferent defect, but the presence of a RPD along with the efferent defect indicates that there is also a afferent problem that is in the optic nerve. Then you look for ptosis, you look for the ocular motility examination or any restriction in the ocular movements. This is basically to rule out the third nerve palsy, in which we know that almost the entire functions of the entire movements of the eyeball are restricted except the abduction and the downward movement, and that is the reason you find the eyeball fixed in a downwards and outward position in a third nerve palsy. Similarly, you look for ptosis. Ptosis can be present in a third nerve palsy as well as in an Horner syndrome also. However, in Horner syndrome, the ptosis is a partial ptosis because of the effect of the Muller's muscle, whereas in the third nerve, it is the levator which is affected, and therefore you get a complete ptosis in the third nerve. So all this ocular examination is very important. Now let us see how do we actually approach a patient with these few examination points in our head. Yeah, before that, always use a slit lamp and examine the pupillary margin very carefully, because I told you about the trauma. Trauma can also cause damage to the pupillary sphincter, and when the sphincter is damaged, it will be shown as sphincter tears in the pupillary area, and that will indicate that the mydriasis or the anisocoria that you are seeing is because of the traumatic mydriasis of the pupil, in which the sphincter is damaged, and therefore the iris sphincter or the pupillary sphincter is not constricting properly in response to light. Now, the first examination point that I told you was to check the patient for anisocoria and difference in pupillary sizes in light and in the dark environment. Now, suppose first we examine the patient in a light condition, and suppose the anisocoria is greater in the light condition. What does it suggest? So, let us see this. Now, in this picture, you can see this is the right eye and this is the left eye. This patient clearly has an anisocoria. The left pupil is much larger compared to the right pupil. Now, when we shine a torch light in patient's eye, what will happen? Ideally, both the pupils, if they are normal, they should constrict. They should be a direct reflex, and there should also be a consensual light reflex. Now, in this patient, you can see that the right pupil is constricting normally. However, the left pupil has remained just like that, or it has not constricted very well. Because of which, what has happened now? The difference between the sizes of the pupil has now gone up. Okay, so this is called increasing of the anisocoria in the light, in the presence of light. Okay, so what does it mean? Whenever the anisocoria is greater in light, it indicates that the pupil which is not constricted is the abnormal pupil. That means the pathological pupil or the pathology lies in this left eye, because this left eye is failing to constrict in response to light. Okay, so this is what is shown in this table, that anisocoria greater in light suggests that the abnormal pupil is the larger pupil. So I hope that is clear now. Now, what are the conditions where we get anisocoria because of the abnormality in the dilated pupil? So, number one is, as I told you, traumatic iris sphincter muscle, right? So, the iris sphincter muscle can get damaged due to trauma. So, such cases you will see the sphincter tears along the pupillary margin, and when you examine the patient under retroillumination, you are going to see certain iris trans illumination defects on the slit lamp examination. So that will tell you that the patient has an anisocoria because of the dilated pupil, and that is because of the traumatic iris sphincter muscle. Now, another condition in which the patient can get a dilated anisocoric pupil is because of the Adie tonic pupil, right? So in Adie tonic pupil, however, so what are some of the clues which will tell you about the Adie tonic pupil is that the patient will have an irregular pupil. Okay, so there's often a sector palsy in atonic pupil in which a part of the iris will have paralysis. So because of that, a part of the iris will only, the part of the pupil will only be reacting to light. And that is the reason why in atonic pupil, the pupillary light reaction is also called the vermiform reactions, because they are very irregular, they're very tonic and slow reaction to the light and also to the convergence. So in atonic pupil, the pupil will be irregular because of the sector palsy, and such a pupil will react very minimally to light reflex, and it reacts to the near reflex. However, the reaction is very slow and tonic, and therefore the name aditonic pupil. Now, one more feature of aditonic pupil is the hypersensitivity to pilocarpine, and therefore when we put this diluted form of pilocarpine, which is 0.1 to 5%, the patient will have reaction to the this diluted pilocarpine. Okay, so if for more clarification about the topic on atonic pupil or Adie's pupil, I would advise you to refer this video which is present on my channel. In this video, I have actually told you about the atonic pupil in detail, why an atonic pupil reacts to 0.125% pilocarpine, and why a normal pupil will not react to the 0.125% pilocarpine. So that is a very important high yield point which all of you should know, and therefore just visit this video once. Now, what are the other causes in which the dilated pupil is the cause of anisocoria? Now, the third cause is the third cranial nerve palsy or the third nerve palsy. Here, usually you will have the patient complaining of ptosis, diplopia, and there will be extraocular muscle palsy also. Okay, so there will be limitation of movement. Apart from that, it can also be because of pharmacological mydriasis. We know that mydriasis happens because of the sympathetic activity, right? So if the person has instilled any sympathetic medications like pseudoephedrine, which is used usually for cold, or if the patient has instilled any drops like cycloplegic drops like atropine, which are anticholinergic, okay, so opposite to the cholinergic effect, which will cause dilatation of the pupil. Now, some patients might be using the motion sickness patches like scopolamine, so that might also cause mydriasis. And sometimes patients on nebulizers, the asthmatic patients who are using this ipratropium bromide, and they're using an ill-fitting mask, that will also cause a unilateral mydriatic pupil. So at this point, I hope it is clear that what are the causes of dilated pupil which can cause anisocoria. So at this point, I would advise that you revise this first before we go to the pupil in which the constricted pupil is the cause of anisocoria. Now, coming to the anisocoria because of constricted pupil. Now, suppose let us consider this patient is now being taken to a dark room. Okay, in this dark room, suppose this is the right eye and this is the left eye. Now, in this scenario, if you can see, what should normally happen in a normal pupil in dark? The normal pupil will dilate in the darkness. Okay, so now in this right eye, you can see that this is the pupil, and this pupil has slightly dilated in the dark. Okay, so this pupil is normal. Now compare it to the left pupil. This is a pupil which is smaller also, and then when you put this patient in dark, the pupil fails to dilate. So obviously here the anisocoria has gotten exaggerated, or it has become greater in the dark environment. However, the abnormal pupil over here is the smaller pupil. Okay, so this is the high yield point here. So whenever the anisocoria is greater in dark, it indicates that the abnormal pupil is the smaller pupil. So I hope that is clear. Now let us find out what are the causes of constricted pupil causing the anisocoria. Okay, yeah. So here the cause could be unilateral exposure to a meiotic agent, right? So this meiotic agent is pilocarpine. So pilocarpine causes constriction of the pupil. So that could be a cause. Number two is iritis, which is a type of anterior uveitis in which the patient will have eye pain, redness, and anterior chamber cells and flares. So usually these signs will tell you that the patient is suffering from iritis, and that is the reason for anisocoria. Then the third cause is Horner syndrome. In Horner syndrome, you will have a constricted pupil, okay, because it is a problem in the sympathetic system. Now, because the problem in the sympathetic system, the pupil will not dilate in a Horner syndrome, and therefore they will have a dilated pupil. They will have a small pupil because of the absence of sympathetic activity, and they will have mild ptosis along with that. Now, the fourth cause is the Argyll-Robertson pupil, which is a syphilitic pupil. In a syphilitic pupil, also, you are going to have an irregular meiotic pupil, and usually this is bilaterally present. However, there will be a small degree of anisocoria, often associated with the ARP pupil or the Argyll-Robertson pupil. Now, if you want to know why in Argyll-Robertson pupil we have meiosis and why it is bilateral condition, I would advise you that you go visit my video on abnormal pupillary series, in which I have explained you about the Argyll-Robertson pupil. Now let us try to understand this ocular examination and various other tests that we carry out further to understand anisocoria. So the first examination was whether anisocoria is greater in dark or is it greater in light. Now we know that whenever the anisocoria is more in dark, the problem is with the constricted pupil, okay, because it is failing to dilate. So here there are two conditions. One is pharmacological meiosis, that means usage of pilocarpine, or it could be because of the Horner's syndrome. Now how do you differentiate between these two? You have to differentiate between these two using the 10% cocaine test. The 10% cocaine test will actually it will prevent the reuptake of norepinephrine from the synapse, right? So what happens in pharmacological meiosis is that there is normal sympathetic innervation and there is norepinephrine present in the synapse, and therefore this cocaine will prevent the reuptake of this norepinephrine, and the norepinephrine quantity will increase in the synapse, and therefore then there will be mydriasis. So the pupil is going to actually dilate with 10% cocaine in the case of pharmacological meiosis. Now, in Horner syndrome, we know that it is a problem of the sympathetic activity. Now, if there's a problem of the sympathetic system, there will be no norepinephrine present in the synapse. If there is no norepinephrine present in the synapse, the cocaine will not be able to cause any advantage in the dilatation of such a pupil, and therefore there will be no dilatation with 10% cocaine, and that will indicate that the patient is suffering from Horner's syndrome. Now, if you want to understand the proper pharmacological tests that we do for Horner syndrome, how do you diagnose and localize the Horner syndrome with these various drugs, whether it is cocaine, apraclonidine, hydroxyamphetamine, and phenylephrine, I would advise that you visit this video on pharmacological tests for Horner syndrome and clarify your concepts about diagnosis of Horner syndrome. So, as I told you, Horner syndrome can be diagnosed with this 4% or 10% cocaine. Okay, so both concentrations are used. So in Horner syndrome, there will be no dilatation of the pupil. Okay, and you can also use apraclonidine 0.1%, but to understand about it, you have to visit my video. Then again, to know whether it is a preganglionic or a postganglionic Horner syndrome, you can use this 1% hydroxyamphetamine or 1% phenylephrine, and that is explained in detail on the video on Horner syndrome. Let's talk about the other end of the spectrum, in which the anisocoria is becoming greater in the presence of light. Now, as I already explained you, whenever the anisocoria is becoming greater in light, it is a problem of the pupil which is dilated because it is failing to constrict in the presence of light. So for such condition, what do you do next? You will examine the patient for the sphincter abnormalities, okay? Then carry out the near reflex and also check for any hypersensitivity of the sphincter muscle using the diluted 0.125% pilocarpine. Now at this point, I think you know why the pupil is hypersensitive in certain conditions and what is the use of using the 0.125% pilocarpine. So now, suppose on slit lamp examination, you find out that the pupillary border is torn. That indicates that the pupil is dilated because of the traumatic iris damage. Second thing is, you find out using a near reflex that there is a tonic near constriction. Along with that, there is sector palsy of the iris and the pupil is hypersensitive to 0.1 to 5% pilocarpine, which is very diluted pilocarpine. That means even when you use this diluted pilocarpine, the patient is showing constriction of the pupil. That indicates that he's suffering from Adie tonic pupil, and the cause of anisocoria here is the Adie tonic pupil. Now, another cause which can happen, another cause of this anisocoria greater in the light is actually the third nerve palsy or the physiological mydriasis. So, how do you differentiate that? In this condition, if you find that the pupil is round and the near constriction, the near reflex is poor, and the pupil is not constricting with 0.1 to 5%, that means that you have ruled out now the aditonic pupil. Now, in this case, the next test to be done is the 1% pilocarpine test. In this 1% pilocarpine test, if your pupil is constricting, that means it is the third nerve palsy. So, a third nerve palsy is a problem of the effector, that means the short ciliary nerves. They are not going to come and supply the sympathetic activity, the cholinergic activity to the pupil, and the pupil will fail to constrict. But if you supply the cholinergic agent from outside, that is the 1% pilocarpine, the pupil is going to constrict, and that indicates third nerve palsy. Obviously, in third nerve palsy, you will have a lot more other clues as well, like complete ptosis and external ophthalmoplegia. Now, what if on the 1% pilocarpine test the pupil does not constrict? It indicates that the patient has used certain anticholinergic agents or any sympathetic agents which are actually causing the drug mydriasis, because these anticholinergic agents like the atropine are actually going to block the receptor where the pilocarpine is going to sit on and cause the pupillary constriction. And as the receptors are already blocked, the pilocarpine 1% test is going to fail. So if the pupil does not constrict on 1% pilocarpine test, it indicates that the patient is suffering from pharmacological mydriasis, and this is how you differentiate between third nerve palsy and pharmacological drug mydriasis. So that's all for anisocoria. Any doubts are welcome. Thank you and have a nice day.